For patients taking oral anticoagulant drugs who require coronary stenting, the optimal antithrombotic treatment has not been known. In the WOEST trial, 573 patients already receiving oral anticoagulants and undergoing coronary stenting were randomized to either double therapy with additional clopidogrel only or triple therapy with clopidogrel and aspirin on top of an oral anticoagulant.
The main result of our study is that in the triple therapy group there is a bleeding incidence of 44.9%, and in the double therapy group the incidence of bleeding was significantly lower, with a total bleeding rate of 19.5%. The main result of our study is that the primary endpoint was met. Oral anticoagulants plus clopidogrel causes less bleeding than triple antithrombotic therapy. Also, the secondary endpoint was met. With double therapy, there is no excess of thrombotic and thromboembolic events. And finally, with double therapy, there is even a lower rate of all-cause mortality. And therefore, we propose a strategy of oral anticoagulants plus clopidogrel to be applied in this high-risk group of patients on oral anticoagulants when undergoing a PCI.
FAME2 investigators compared clinical outcomes of fractional flow reserve-guided PCI versus medical therapy alone in patients with stable coronary artery disease, an indication for which PCI has not been shown to improve prognosis. 1,220 stable CAD patients scheduled for 1, 2, or 3 vessel DES PCI were enrolled. Fractional flow reserve was measured in all target lesions. If FFR stenosis was significant, the patient was randomized to PCI plus medical therapy or medical therapy alone. If FFR was above 0.8, the patient was assigned to a parallel medical therapy alone registry.
In the patients of the registry, the patients without ischemia, clinical event rate is very low under medical therapy. Excellent clinical outcomes in these patients, no need for PCI. In contrast, in patients with ischemic lesions, there is a clear difference. Patients treated with medical therapy alone have a significantly higher rate of urgent revascularizations and thus of primary outcome in this study as compared to the patients randomized to receive PCI plus medical therapy. First, PCI is useful in patients when they are properly selected. Second, when at the outpatient clinic you have a suspicion of coronary artery disease, there is no reason nowadays not to go straight to the cath lab, because there you can obtain anatomy and function, same time, same place.
The CORE 320 study evaluated the potential for the non-invasive detection of flow-limiting stenosis by comparing 320-row detector CT angiography followed by CT perfusion to classical invasive angiography followed by SPECT in 381 patients referred for coronary catheterization.
The main findings of our study are that with a non-invasive test that combines information from anatomy, like CT angiography, if we combine it with CT perfusion, we can have a full picture of which cholesterol buildups or which plaques in the coronary artery are causing a perfusion deficit to the muscle of the heart.
Researchers have long suspected that women with stable coronary artery disease have worse outcomes than men, but data presented during the first ESC 2012 clinical trial update session from the Clarify registry have provided new information on this issue. Clarify is an international prospective registry of more than 33,000 stable CAD outpatients. In Munich, Gabriel Steg presented the one-year follow-up outcome comparison between men and women.
We found similar crude and adjusted rates of one-year mortality and cardiovascular events in men and women with stable CAD. Longer follow-up of this population, up to 5 years, will provide far many more events, far much power, and therefore should provide further insights into gender issues in stable CAD.